Now we get into therapy, and this is something that I think we all know. If we were consulting with an individual patient, we could be in the room for an hour, and we can't allocate an hour to talk about upfront therapy. But I'm going to start when we'll kind of walk down the list and really highlight differences in our panel. So I'll get John to start, and I'm going to give you a hypothetical 60-year-old patient, fit, newly diagnosed with mantle cell, and a hypothetical 75-year-old patient, maybe some comorbidities, newly diagnosed with mantle cell, and we'll say both need treatment. Kind of how you decide what to do, and again, you know, just kind of short, general sound bites, because obviously there's a lot of nuance to this.
Right, and you know, when you introduced me, John, you said I'm from Seattle, so that means we transplant every patient, and of course that's a stretch and a joke, but you know, that's a common approach, is to consolidate patients with aggressive treatment in many cases. I'm not sure it's always the right thing to do, but typically an approach I think that many of us still are employing, at least I would say in the Pacific Northwest, is to get people to a good remission, a very deep, complete remission. How you get there, of course, is very controversial. I guess we can talk more about that. If it's in a younger patient, maybe hyper-CVAD, in an older patient, maybe it's bendamustine or Rituxan. I typically tend to be very aggressive with patients based on what they can tolerate. And then it's not uncommon to consider an autologous transplant in first remission for those patients. So the 60-year-old fit, that's an approach I probably am going to take. I'm not crazy about hyper-CVAD even in a 60-year-old, but getting them to a good remission with bendamustine rituximab or an abbreviated course of hyper-CVAD is what I might desire to do, and then to collect stem cells and go to transplant. The 75-year-old's a little more controversial, obviously. Does transplant really help somebody who's already in their mid-70s? And I would say usually in that kind of case, I'm going to stay away from transplant and try and maintain them as long as I can with a good remission, perhaps even with some of the newer drugs that we'll end up talking about.
And is that someone you typically would use BR with, or
I probably would.
Mm-hmm.
I probably would. I think bendamustine rituximab is very well tolerated in most patients, but I think one of the most important things that we have to remember with bendamustine is that it's very myelosuppressive, and there's no rule that says you have to give 6 cycles of the regimen. I typically might assess a patient after just 3 cycles or so, and not uncommonly, if I think the risk is relatively low, I'll just stop there and always know I could give a little bit more in the future, although I'm not a fan of coming back to more bendamustine repeatedly.
John, so do you ever consider bendamustine rituximab for patients for whom you potentially could then perform autologous stem cell transplant?
So that's a difficult thing. You know, we have published data actually that shows that you can collect stem cells after people have had bendamustine. And actually, we even published a paper of using bendamustine as a mobilization tool. It wasn't highly successful, but it can be done. I think at the end of the day, for me now, with the use of Mozobil and the ability to mobilize stem cells with these new agents, that it's not typically a factor. In fact, it's very rare not to be able to collect stem cells in somebody who's had prior bendamustine now.
So Andre, I'm guessing your approach is similar. Anything different about your strategy? Younger, BR-based therapy, older, more intensive, and do you typically use hyper-CVAD or something else for the younger person?
I mean, I think one of the real key philosophy in treating mantle cell lymphoma is that I think it's one of the diseases because they become chemo-resistant over time. Achieving a deep response, early response, impacts the outcome. So I think if a patient is dose-intensive fit, hyper-CVAD or chemo followed by transplant, I don't think there's a big difference. There was actually an abstract at ASH that we can refer to that was looking at a large 1,200, almost 1,200 patients and looking at the impact of high-dose therapy consolidation in first CR. So there's a bit of a bias because it's a retrospective analysis on the CR patients, but clearly the dose-intensive strategies have really pushed the PFS, and now that's why we have a median PFS in well in excess of 5 years, even in the real world, up to 7 years at least. In the original hyper-CVAD, and that's always a problem in the trials because the trials always have an easier picture than the real world. And at 10 years, there's still 52% of the patient that we are still have not relapsed. So in a younger patient, that only becomes an option. One of the questions that remains on now that we'll have the ability to integrate novel therapies, and then maybe we'll talk a little bit more detail in the subset P53 on how that can change the picture. The next question is that the BR in a non-intensive therapy patient, fit or an older patient, The BR data is not necessarily that impressive, I would argue, and although it was proven in a trial to be slightly better than R-CHOP, but it offered a platform to combine with another agent. So the BR plus vanacibrutinib was completed. We're waiting for the result. Same thing with the acalabrutinib, and it offers a platform. I think out of the clinical trials, one regimen that I find better in terms of duration of response and outcome is RBAC, and a modified RBAC with a 500 of cytarabine that gives actually very good results in the front line. That's what I would rather do of a trial.
Yeah. So I'm a big fan of BR, both in younger and older patients, and I think BR with rituximab maintenance, which has been kind of an indirect, we'll come back to maintenance in a minute, is something that I commonly use. Briefly, Steve, your thought on blastoid up front. If a patient comes in with blastoid, what do you, how do you approach those patients?
I'm less influenced by morphology than I am by genetics. And there tends to, however, to be a correlation between morphology, Ki67 score, and cytogenetics. So you're much more likely to see a blastoid patient with a high Ki67 score and a P53 mutation, or you know, and aggressive, more of an aggressive clinical presentation. So, but again, it's not 100%. I mentioned the one outlier that had a ugly morphology, but he did well for years. So anyway, I would echo with what Andre said and what John said. I think that in a patient that needs treatment, obviously I'm setting aside the approach to somebody that's P53 mutated, because I think chemotherapy in those patients is not going to give, alone is not going to give you a very long success. And certainly with mantle cell lymphoma, once you've been treated and you progress, the prognosis becomes, unlike other small B-cell lymphomas, becomes guarded. It's really the relapsed mantle cell patient that has a bad prognosis. And first remissions, if you do it right, can be quite durable and a benefit. So I think if you're using chemotherapy, you want to get into as deep a remission as possible. I like ARIS-C as part of the cytoreduction in younger patients under the age of 60, and then auto transplant. And you know, we've been using DAP or DAP alternating with R-CHOP and auto transplant in those kinds of patients.